Welcome back to Get Lit, the Dermatology Digest Literature Lessons podcast with Dr. Ted Rosen, a professor of dermatology at Baylor College of Medicine in Houston, Texas, and the editor-in-chief of the Dermatology Digest.
Hi, this is Dr. Ted Rosen, editor-in-chief of the Dermatology Digest, with another edition of Let's Get Lit. Let's talk about some new dermatology literature. Let's get right to it. In the July issue of the Journal of Cosmetic Dermatology, there was a pretty big-sized study on rosacea patients from China. So you have to take that with a small grain of salt. May or may not apply to our American population, but it's interesting. They had a very high propensity towards developing clinical depression. They were often smokers. I wonder about the heat from smoking, activating those heat receptors in the neck and dilating the blood vessels on the face. They were regular users of alcohol, which we know to associate with rosacea. And they also were frequent exposure to the sun to the point of sunburn and taking hot baths, again, heat dilating blood vessels. So interesting predispositions in Chinese rosacea patients, probably largely true in our American rosacea patients as well. In the next month, the August issue of the same journal, Journal of Cosmetic Dermatology, there was a retrospective Turkish study comparing the safety and efficacy of a variety of topical agents to treat acne during pregnancy. Of course, we want safety is paramount there, right? And they found that clinical improvement and patient satisfaction both were better with azelaic acid than with topical erythromycin or topical clindamycin. Safety and tolerability were excellent with all three agents, but they found clinically azelaic acid to be the best. In the August issue of Frontiers in Medicine, there was a relatively small study, 141 patients of atopic dermatitis who had cleared on dupilumab and then stopped the drug. What they found was a 23.4% relapse rate. That's not too bad if you consider. And the median follow-up was about a year. Who was likely to get recurrence in this particular study? Men more than women, and when the treatment to clearing was short. In other words, they only got dupilumab for 16 weeks or less, then stopped it, they were likely to recur. If they'd gotten it longer, they were less likely to recur. In the September issue of Cutis was one of my favorite all-time articles, like ever. And they were talking about how to lessen the discomfort associated with pre-procedure injection of local anesthesia. Having had a fair number of skin biopsies myself, I read this with great interest. And we all know about using little vibrating things around the site that's being injected, but they found you don't even need to do that. They found that tapping on a bony prominence, such as the shoulder or the knee, distant to the site of surgery, decreases the discomfort associated with that injection of local anesthetic. Interesting. And varying the rhythm and intensity of the tapping enhances the distracting effect of this technique. Try it. I think it actually works. I've tried it now a couple of times. In the September issue of JAMA Dermatology was, I think, an important study. It's a large-scale retrospective chart-based study from the Veterans Administration looking at oral nicotinamide. And what they found was overall a 14% reduced risk of skin cancer. However, that risk reduction increased to 56% when the nicotinamide was started after the very first skin neoplasm. So I think that's an important point. don't wait. If you like this as an option for prophylaxis against additional skin cancers, start the nicotinamide 500 milligrams twice a day after the very first lesion. They also found this additional finding was that solid organ transplant recipients also benefited from oral nicotinamide. They had a 53% reduction in cutaneous squamous cell carcinoma. In the July issue of JAMA Surgery, they did a study looking at National Cancer Database involving over 11,000 patients. And what they were doing is comparing surgery, immunotherapy, or the combination of both. How well did they do in managing malignant melanoma metastases? And it turns out it really varies widely by site. For example, with distant nodal metastases, combination therapy or surgery alone actually outperformed immunotherapy alone. So hopefully, with a metastatic melanoma patient, your medical oncologist knows which individual or combination therapy is appropriate based on site. In the August edition of JAD, there was a nice paper on anogenital basal cell carcinoma. They're pretty uncommon, right? But they collected 50 lesions. They found, first of all, that the average tumor site was pretty good. It was 4.1 centimeters. In women, the vulva was the most common site affected. And in men, the perianal region was the most common site affected. And in women, there might be underlying lichen sclerosis. And I think of underlying lichen sclerosis as leading to squamous cell carcinoma, but this was basal cell carcinoma. In the August issue of the JEADV, the Journal of the European Academy of Dermatology and Venereology, they had published a study. It's a large study looking at melanoma and pregnancy. It wasn't really that long ago. In the 1950s, it was said that melanoma and pregnancy led to horrible outcomes and so forth and so on. If you ever had a melanoma and you were pregnant, you should abort the baby. You should never, if you had a melanoma, have a pregnancy again. Well, in this particular study, which was looking at the outcomes of 690 pregnancy-associated melanomas in a cohort of 1,786,000 plus pregnancies, they found that women with either in situ or invasive melanoma had a similar long-term survival and had similar perinatal outcomes when compared to pregnant women without melanoma, i.e., melanoma and pregnancy can mix. You treat the melanoma as you must, but don't expect horrible bad outcomes either for mom or baby. In the July issue of the journal Surgery, again, I think an important article. You know, if you do wide local excision of an acromelanoma on the foot, that usually involves removing all the plantar subcutaneous fat. That's cushion. That helps making walking possible. And they found, this was a Japanese study, pretty good size, almost 500 individuals, that there was no difference in a whole variety of survival measurements between deep excision margins that included all or just a portion of the plantar fat. In other words, you could do a wide local excision and still leave a little bit of that plantar fat there to act as a cushion, allowing non-painful ambulation. Again, Japanese study, but I think very, very important to consider with acromelanoma. In the September issue of JAMA Dermatology, there was a retrospective Greek study of 400 patients, which was pretty good, that disclosed that recurrence or metastases from melanoma in situ was vanishingly rare if the initial excisional biopsy demonstrated clear margins. And that was true even if the initial biopsy was never followed by definitive wide local excision. Made me think, are we maybe over-treating melanoma in situ? If the initial biopsy was excisional and included clear margins, maybe we don't need to go back and re-excise. In the October issue of Acta Dermatovenereologica, there was a Dutch study detailing 51 advanced basal cell carcinoma. The vast majority of metastatic basal cell carcinoma involve lymph nodes only, although about a quarter did develop other distant metastases. They pointed out that by the time basal cell becomes metastatic, it has a poor prognosis. And in this particular study, the 5-year disease-specific survival was only 30%. So metastatic basal cell needs to really get a lot of attention. In the September issue of the New England Journal of Medicine was, I think, an important initial publication regarding GLP-1 receptor agonists by mouth. There are a lot of them that are available by injection. And almost every meeting I've been to in the last year, someone's talked about we need to start administering GLP-1 receptor agonists for diabetics or for weight loss, and for patients who have hidradenitis, for patients who have psoriasis, because it makes those diseases easier to control. But, patients may not want another injection or even the first injection. So in this September New England Journal of Medicine article, it discussed the results of orforglipron, which is an oral GLP-1 receptor agonist. Daily doses ranged from 6 milligrams to 36 milligrams, very well tolerated, and weight loss ranged from 7.5% to 11.2% reduction, very dose dependent. And that compared with about 2% weight loss with placebos. So there may be an oral way of helping control diabetes as a comorbidity, or weight as a comorbidity with things like psoriasis and hidradenitis. In the September issue of the Journal of Cancer Research and Clinical Oncology, I think was an important article for those of us who do treat patients who get dermatologic manifestations from cancer treatment drugs. Specifically, they were talking about capecitabine for leading to hand-foot syndrome, the erythema and desquamation, numbness and tingling. It's a real problem. And they said that the co-administration of diclofenac may prevent or significantly decrease the severity of the hand-foot syndrome. They also mentioned less exotic things like topical urea, topical lactic acid may alleviate these symptoms. And there's actually a significant amount of literature that shows use of a slurry of, I know you're going to laugh at this one, but certain non-permanent tattoo dyes and water, and a slurry may prevent or actually treat this hand-foot syndrome. So I don't know, but diclofenac seems pretty reasonable to me. In the March issue of the JAD, there was an interesting article, and it was talking about what can happen from tattoos. Now, we all know you can have allergic reactions to various of the dyes used in tattoos. And I think we're all aware that post-tattoo infection, particularly with atypical mycobacterium, can occur. But the interesting thing that this article pointed out was that tattoos are also associated with the initiation of neutrophilic dermatoses, pyoderma gangrenosum, not at the tattoo site, but elsewhere, a variety of cutaneous neoplasms, particularly lymphoma. Maybe that tattoo ink migrates to the lymph nodes. We know that happens, but it can act as a carcinogen or co-carcinogen, and that even dermatophyte and deep fungal infections can accompany tattoo placement. So there are lots of reasons not to get a tattoo. In North America, it's estimated now that 1 in 4 individuals, Canada and the US, have tattoos. It's also estimated that about 40% of individuals have tattoo regret. They're sorry they got it after the fact. So maybe better not to get it in the first place. In the August issue of JAMA Dermatology, there was a published study using data gathered from 23 countries across 6 continents involving 22,743 participants. And what they were trying to do is estimate the global prevalence of hidradenitis. And they estimated it's about 1% globally. Now, it does vary from country to country. For example, the lowest level prevalence of hidradenitis was in Bangladesh, and the highest was in Saudi Arabia, interestingly enough, but about 1%. So it's not that uncommon. In the August issue of the New England Journal of Medicine, I know this isn't widely applicable, but I thought it was worth mentioning at least. There was a 4-year study done on Madagascar. That's an island off the coast of eastern part of Africa, where plague is still endemic. And they compared oral ciprofloxacin to parenteral aminoglycoside, followed by ciprofloxacin. And you know what? 10 days of monotherapy with oral ciprofloxacin was equally effective as using parenteral aminoglycoside first. In the United States, we have an average of about 7 cases a year, but it can go up to almost 20 cases a year, depends on the year, of bubonic plague, mostly New Mexico, Arizona, Colorado, and scattered places in California, and often transmitted by contact with infected cats. But if you happen to see a ulceroglandular plague, oral ciprofloxacin works just fine. In the September issue of Dermatologic Therapeutics was a really nice study looking at a lot of other published data, so a big meta-analysis, to see which psoriasis therapies worked quickest. Fastest time to onset of action were the interleukin 17 inhibitors, followed by the interleukin 23 inhibitors, followed by the JAK and PDE4 inhibitors in that order. And this was an analysis of some 45 controlled trials. So just keep that in mind. Most of the time, the speed of onset is not that critical. Patients have had psoriasis for a while, but maybe they want to clear their psoriasis before a honeymoon or an anniversary party or a wedding. IL-17 and IL-23 inhibitors in that order are the fastest. In the June issue of the JEADV, there was a meta-analysis of 53 journal articles covering, get this, 287,769 patients. The reason I emphasize that is because of their conclusions, which were that the use of TNF alpha inhibitors was not associated with the de novo development of congestive heart failure, nor the worsening of pre-existing congestive heart failure. And I think our sort of standard way of looking at it is don't give TNF alpha inhibitors to people who have congestive heart failure and stop them if they develop congestive heart failure. But according to this article and review of a lot of patients, that association is maybe not so strong as we felt. In the August issue of the Journal of Cutaneous Medicine and Surgery, I think was an important article for us to remember that drugs may trigger generalized pustular psoriasis. Now, we have newer and even better ways of managing generalized pustular psoriasis, but remember, it can be associated with a drug. And of course, then the most important thing is to stop the drug. What drugs, you ask? Well, some of them are ones we routinely use and some aren't. But among the drugs that can participate and start pustular psoriasis are terbinafine, hydroxychloroquine, adalimumab, dupilumab, and ustekinumab. Those are all derm drugs where we can actually initiate generalized pustular psoriasis. So be careful. We don't see much of that, but be careful to ask if someone's been started on one of those drugs, or perhaps we started the drug. So yes, we have new ways of treating that, but the number one thing would be to stop a potentially incriminated drug. And then last but not least, I want to just mention an article that was in the July issue of Arthritis Care and Research. Comes from Korea. It was a nationwide retrospective study of patients diagnosed with systemic scleroderma between 2004 and 2021. And they were compared to age, gender, matched controls. And you can do that when you only have one national healthcare system. And they were looking at cancer risk. And it turns out systemic scleroderma has a threefold excess risk of cancer compared to a matched control cohort. What did patients get? Multiple myeloma, eye cancer, and laryngeal cancer, not your common types of cancer. So I think that association with systemic scleroderma probably is accurate. It certainly was in this Korean study, and we should be watching for those kind of cancers in the patients we diagnose with systemic scleroderma here in America. Thank you so much for listening. I hope you've gotten a few diagnostic, therapeutic, or watch for this pearls from this edition of Let's Get Lit. This is Ted Rosen, Editor-in-Chief of the Dermatology Digest. I'll see you again in the future.
Thank you for listening to the Dermatology Digest's Get Lit podcast. For more information on any of the studies referenced, visit thedermatologydigest.com.